All right, so we'll go ahead and get started on part two of this. One thing I was just thinking when I, finished part one is I need to point out because I keep using this word obstructive pathology, right? Obstructive, chronic obstructive pulmonary disease. What does that mean? What does that mean? So you have to realize that there's restrictive pulmonary disease and obstructive pulmonary disease. Right now, we're talking about obstructive pulmonary disease, and I'll have you know that, especially on your exam, 95% of the time or more, it's going to be obstructive pathology. Okay, we see this more common. Restrictive pulmonary disease are pretty rare, relatively speaking. They're rare. So what does that mean? When in doubt, pick obstructive. That's the right answer. Okay, because restrictive disease is very rare, like sarcoidosis, or that's probably like the biggest one, sarcoidosis. So you don't see a lot of restrictive lung disease, and maybe some type of cancers, lung cancers maybe. But anyways, a foreign airway body obstruction, something like that. But foreign body airway obstruction. But yeah, those are rare. So what I want you to know is what is obstructive. So remember, we can get air in pretty easily most times, right? Like that's an active process. It's pretty easy. But obstructive pathology, we have a hard time getting air out. Okay, and so how this presents is we have a patient who has a hard time getting air out. So I could write a test question and say, is asthma a restrictive or obstructive lung pathology? So it's obstructive. Okay, another question. Do patients with asthma have a hard time getting air in or air out? They have a hard time getting air out. Okay, same thing with COPD, emphysema, bronchitis, bronchiolitis, emphysema, asthma, right? The list goes on and on. It's a hard time getting air out. And we have to understand that that's the problem. They can get air in, they have a hard time getting air out. And so, that would make sense in emphysema and stuff like that. And students struggle with that. So just realize, I hate giving statements like this, but for the sake of getting points on your exams in the National Registry, when in doubt, it's obstructive. Okay, they're probably going to test you on obstructive pathology. It's by far the most common thing you'll see, especially as an EMT. Okay, now with that moving forward, we have these things called anaphylactic reactions. So this is an allergic reaction. It's a type 1 hypersensitivity reaction. So basically, an allergic reaction, it's like the most extreme asthma attack, right? You can imagine. And it's very similar to asthma. Actually, it's the same type of hypersensitivity reaction. It's just very extreme. So what happens is, like, for example, I'm allergic to tree nuts, so pecans, right? And so if I were to go chewing on some pecan pie, my body will look at pecan, and in my case, it's pecan. It may be a bee or an ant or something like that for you, or peanut butter. But if I were to eat a piece of pecan pie, my body would panic and say, it would recognize pecan as an antigen, right? A bad thing, and say, go to war, give it all we got. It goes full blown nuclear on it. Like it dumps everything it has to fight this pecan. It's an exaggerated immune response. And so it's a very severe allergic reaction. And so just like in asthma, how we get wheezing and swelling of the bronchi and edema and mucus production, right? And this huge histamine release, we get this massive nuclear histamine release that happens in anaphylaxis and an anaphylactic reaction. And so you end up with distributive shock. One, so distributive shock, remember, is when all our vessels become really leaky because of this histamine release, but we also end up with this characteristic airway swelling. So the mouth, tongue, airway, like the oropharynx, can swell, and it can swell so much it can close off your airways. So the whole oropharynx, especially your tongue, will swell. It's called orolingual angioedema, okay, or it's called, sometimes you'll see it called angioedema. And so basically it'll swell so much you can't get air in, and that becomes a problem. But you'll also present with wheezing and tachycardia and eventually hypotension, low O2 sats, ultramental status, anxiety, okay, hives, right? Hives, wheals, urticaria, same thing. All three of those are the same thing. And so basically, you'll end up with this exaggerated immune response that's very fatal. So most reactions occur within 30 minutes of exposure to allergen, and if untreated, they'll probably die within the first hour. Very severe. This is very, very deadly. So what's the treatment for this? It's short-acting beta agonists like albuterol. We also give epinephrine. So this is where EpiPens come into play. And so we'll give an EpiPen right to the thigh. And I have an well, I didn't grab one, but I have an EpiPen in my backpack. I never had to use one, but basically you give an EpiPen, okay? And so basically it'll cause airway swelling. And so this is like asthma that's very exaggerated. It's very, 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 this is very lethal, okay? I've said, even as a paramedic, right? Or a physician, whatever you want to be, this is the one where you better move quick because time is not on your side on this one, right? Right? Chaos is contagious. I'm not saying be chaotic and manic, but I'm saying this is a very, very rapidly fatal disease when this happens. Very fatal. So they do need epinephrine, albuterol, Benadryl, um, IV fluid. We don't give IV fluids, but IV fluids, like this is very, very fatal. Okay. Now, there's this thing called a spontaneous pneumothorax. And I'll have you know that the word pneumo means air in the thorax, okay? The chest, the thorax. So what happens is, in this case, it's spontaneous. Well, let me just tell you. Typically, you see a pneumothorax in trauma, right? Like a gunshot wound to the chest, or a blast, or like an explosion, or a stab wound, or something like that. Now, we also can see this spontaneously, right? So it can just randomly happen. Now, who does this happen to? Those with emphysema, okay? So remember, people with emphysema, the shopping bags for their lungs, their alveoli, their lungs are not very elastic. So you can imagine if you were to blow up a Walmart bag really big, it's really easy to pop compared to like a regular elastic balloon. So that's who gets this. Who also gets this is tall, young, slender men, okay? Not my opinion. That's who gets these. And so what happens is you can get something called a pulmonary bleb. Okay, it's like this little like bleb, like it's a little chunk, right? They can be a weakness. And so what happens is that can blow. So you can literally have a puncture in the lung parenchyma. So as you can imagine, air will start leaking out of the lung, okay? Into the thorax. So we get the word pneumo, air in the thorax, okay? And so again, this is caused by trauma a lot of times, but in this case, being a spontaneous pneumothorax that they're talking about, this is how this presents: is you'll end up with air leaking out of the lung into the pleural space, into the thorax. And so as air will build up inside this cavity, it starts collapsing the lung, like physically collapsing the lung. And while it's collapsing the lung, it'll build up pressure. And if it builds up enough pressure, you can end up with a type of shock. What type of shock is it? I'll give you 4 options: cardiogenic, obstructive, distributive, or hypovolemic. It's obstructive shock. Because what happens is you end up obstructing, you end up literally pushing on the heart and the great vessels, right? Right. Remember, the vena cava is right here on the right side. This is the patient's right side, by the way. How do I know that? Because the vena cava is right there. So this is the vena cava. And so it's a really big vein. And so what happens is this can get pushed on, and we can end up with a pathology called tension pneumothorax, to where there's tension pushing on the lung, pushing on the heart, pushing on the great vessels, and this is rather fatal. Okay, so there is a treatment for this that paramedics do. EMTs do not do this, but I'll let you know what the treatment is. You basically stick a needle right here into the chest, and you allow this air that's built up in this like blue space, the pleural space, to escape. And so that's the treatment for this, and I've done this a few times. It's pretty cool. You feel pretty cool when you do it. But it's pretty rare that this happens, but it can happen. So you ask yourself, how does this present? Well, it presents with absent lung sounds, okay? So, or diminished lung sounds on that side. So again, if the lung is collapsed, it's collapsing on itself because air is escaping and pushing on it, you'll end up with diminished lung sounds on that affected side. So this will present an exam. They'll always tell you that there's diminished or absent lung signs on one side, okay? And then if they want you to think it's a tension pneumothorax instead of just a pneumothorax, and pneumothorax like this, it's not. This is a problem, right? But it's not like a spontaneous pneumothorax. If it's a simple pneumothorax, it is a problem. It needs treatment typically, but it's not fatal. Where it's fatal is when it turns into a tension pneumothorax. And so what they'll do is they'll tell you, like, patient, tall, slender athlete, just ran a 400-meter race. Now he's complaining of shortness of breath. Upon auscultation of the lungs, you notice there's absent right-sided lung sounds. His oxygen saturation is 92%. It remains at 92% on a non-rebreather mask, this thing, right? And he's breathing 25 times a minute, right? Whatever. That is, they're telling you, they're really trying to push you to think, oh, this is a spontaneous pneumothorax, okay? So watch on exams for people with emphysema or prior lung disease, or a young, tall, slender man. That's who it typically happens to, okay? Now, again, you can imagine someone with a collapsed lung, they'll complain of acute dyspnea, right? Typically, they'll complain of pleuritic chest pain, right? So chest pain up underneath the lungs, okay, has a distinct feeling, and it's described as pleuritic, okay? Now, the severe findings, when this becomes life-threatening, is they'll have an ultramental status. Will all be dipped, right? If you drop an entire lung, right, you're not going to be able to perfuse the brain as well. It's not going to get as much oxygen that it demands, so you'll end up with ultramental status. One of the first things we see in shock, right? Ultramental status. Cyanosis, which is a bluish tint of the skin. Tachycardia, an increased heart rate, right? Unilaterally decreased breath sounds, right? They will tell you that. They will tell you that. Local hyperresonance to percussion. Okay, this is fancy, but basically, you could do this to yourself, right? If I were to, it's hard to show you. If I were to tap on my chest, right? Versus, so what I'm doing is I'm taking my finger and I'm tapping on it, and then tap on my stomach. It has a different sound. My stomach doesn't. It sounds more dull. If I do it on my chest, it sounds more like a drum. Okay, so when you do this, I mean, you're not going to be doing this in real life, but in the back of an ambulance. But you'll sometimes see this on exams where they'll say there's hyperresonance to percussion. What they're saying is hyperresonance is it's more of like a tympanic sound, right? It sounds more like a drum because this area is empty, like a drum would be, right? Compared to my belly, it's filled with Taco Bell right now, or it's actually Thanksgiving food, and so it has more of like a dull sound to it. Like you could also have subcutaneous emphysema. What's subcutaneous emphysema? Subcutaneous meaning below the skin, emphysema, air. So pockets of air. So you end up with pockets of air up underneath the skin. And I've seen this. And so basically it looks like puffy skin, okay? Like cracklings, right? And so when you push on this skin, it has a very characteristic sound and feel of Rice Krispies, like Rice Krispie treats, right? With minus the marshmallows, just the cereal. When you push on that, it has a sound, right? It crackly. And so you can actually see this in people with pneumothorax, whether it's from a stab wound or a spontaneous one, you can see that. And a very like ominously late sign is tracheal deviation. So remember, the trachea is the wind tube in the center of our throat. And so when you have a pneumothorax that's turned into a tension pneumothorax that's very fatal at this point, you can end up with tracheal deviation pushing away from the side of pneumothorax. What does that mean? So if my right lung is so collapsed that it is pushing on my heart and my great vessels, it'll push my trachea with it towards the left side. Okay, so that's very ominous if that happens. Like they're gonna die. Very bad sign when that happens. But just know you can see that on an exam. They'll say, "Oh, patient has tracheal deviation to the right. He has absent lung sounds on the left. He has subcutaneous emphysema up in his neck. You know, he has hyperresonance on the left. You know, all they'll paint that picture for you on exams. So just watch for it." Now, with that, we can also get this things called pleural effusions, and this is essentially fluid outside of the lung. Now, this isn't blood, by the way, like red blood. This is typically just fluid, okay? And we typically get these from infection. Almost always. We can also get it from heart failure or cancer, right? And those become malignant. But irritation, even radiation. But this is typically from infection. It can also be from heart failure. So if someone gets a big O pneumonia, right? They can end up with a pleural effusion. Pneumonia, you know, like lung infection, like a lobular pneumonia. And so basically how this will present is they'll be short of breath, okay? And when you listen to their lungs, it'll be diminished or absent in that area, okay? Or like dull to percussion, hyperresonance too, or no, hyporesonance. And so basically how this will look is like this, okay? You'll hear decreased breath sounds. They might even use the word absent, but decreased is more accurate over the region of the chest where the fluid's at, right? So in this case, this is the patient's right. And again, you're not expected to read x-rays, but I thought this would be helpful, right? This is the patient's right, this is their left, okay? So on the patient's right side, this should not look like this, right? This should be the diaphragm. It should look like this side, right? And so what happens is right here is pleural effusion, right? So there's a bunch of fluid sitting down there. And why this is, in this case, it looks like pneumonia, like a interstitial pneumonia. And so this could, or it could be from a lot of different reasons, but pneumonia, heart failure are by far the most common, cancers. So how does this present? The patient, they'll have decreased lung sounds wherever it is. These tend to be gravity dependent, right? Since the lung itself is not like collapsed like an attention pneumo or a pneumothorax, they're gravity dependent. So the patient will almost always want to sit upright. Remember, shorter breath patients, we make them sit upright. And the definitive treatment is fluid removal. We don't do this in the pre-hospital environment. In fact, we don't really do this in the ER very often, but it is to remove the fluid or to just sit and wait and let the body reabsorb the fluid. But that's rare. Like you don't really know the treatment for this. It's supportive care for us. So we might have to give them some oxygen, and coach their breathing. The problem with a pleural effusion is it can become severe. Like it can end up here, and it can end up almost completely like taking up the thorax. And so there's a lot of problems with this, but it can become severe, and it can become so severe that you do have to intervene and drain it in the ER. Like EMTs and paramedics don't do that, but it's just kind of something to know. These happen more than you think. Like you'll see this a lot in the nursing home, and paramedics miss it, right? Because we don't have X-ray vision. They'll just think, oh, they're diminished in their bases, right? It's because they have a pleural effusion. So it doesn't really mean. I mean, it has clinical value, but maybe not in the pre-hospital environment. Now, this next thing is confusing, and it's been confusing paramedic students and EMT students since the dawn of time. So let's go. So here's how this presents: a pulmonary embolism. So an embolism, so pulmonary lung embolism is a blood clot that is floated. Okay. Here's how this will typically happen. This is the stereotype, right? The prototype is someone will have some type of surgery or be hospital bound or be sitting for a long period of time. And up underneath your knee is a vein. And what happens is when your knee's bent like that or you're sitting for a long time, it's a crowd favorite for clots to develop there in the vein, right? Remember, veins go back to the heart. And in this case, since it's down in the leg and not in the lungs, it's deoxygenated blood. So this clot will form, okay? And again, this is usually someone who's in the hospital or after surgery, or they're a flight, or they're across the road trucker or a flight attendant or something like that, or they're doing like an international flight that's 16 hours long. They'll usually tell you something like that in the vignette. It's someone who's sedentary, someone who's wheelchair bound, blah, 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 right? Someone who is sitting for a long period of time. And this clot will form. And how we know that this clot will form is the patient will typically complain of a red, hot, swollen extremity from the knee down with pain. So as you can imagine, if we have the vein at the level of the knee obstructed with a blood clot, okay, distal to that, right? So from the knee down, it becomes red and hot. And so because there's increased venous blood sitting there. And so they'll usually say in the vignette, the patient was complaining of knee or leg pain the day prior or the day of, right? And so they're telling you that's what's called a deep vein thrombosis. What's the difference between an embolism and a thrombosis or a thrombus? Is an embolism is a thrombus is a blood clot, and an embolism is a blood clot that has started to move. It is broken off and it's moving in the vessels now. And so that's the difference. I'll say that again. A thrombus is a blood clot or a clot within the vasculature, and an embolism is when it has started moving. I'll say that again. A thrombus is a blood clot, and embolism is when that blood clot has started moving. And so we end up with these things called DVTs, deep vein thrombosis, and it'll travel its way up to the heart, okay? And so when it goes up to the heart, it goes through the great vein of the legs, right? The large veins, up into the iliacs, right? Into the inferior vena cava, down into the right atrium, through the tricuspid valve into the right ventricle, and it goes out through the pulmonic artery. Well, when it gets to the pulmonic artery, it's the pulmonic artery will branch off to smaller branches. Well, if this clot is the size of this, right, and the lumen it needs to go through is now the size of that because it's decreasing in lumen size as it goes further and more distal, it'll get stuck. So when it becomes stuck, you have this backflow of blood. So now you end up with a perfusion mismatch. And let me tell you how this presents. Look. Again, inferior vena cava, right atrium, right ventricle, pulmonic artery, right? And eventually it'll become lodged in the pulmonic artery. Yes, the pulmonic artery is deoxygenated blood. We've talked about this. And so if this happens, more commonly than not, it'll end up down here. Now, I do want to point something out. There is such thing as something called a saddle thrombus. This is instantly fatal. If it gets lodged right here to where it blocks off blood flow to the left lung and the right lung, so if there's like a big clot sitting right here at the bifurcation, that's called a saddle thrombus, and it is it's like, boom, they're dead, okay? So that does happen occasionally, but more often than not, it doesn't, but it does happen. And I've seen that clinically. I've seen that in the field. And so basically, when you shut down the blood flow to the left side of the lung through the pulmonic artery, it gets clogged off, the left pulmonic artery. you end up with a perfusion mismatch, right? So think about this, and students throw their hands in there and give up on this. Don't give up on me, right? So remember this whole VQ thing, right? Ventilation. So in this particular patient, is air still coming in and out of the lung? It is, right? Air's not affected in this case. They're still ventilating. Air still goes in and out, okay? That's not a problem. So let's just say we give them a 10 for the V score. But since we shut down the entire left side of the lung, instead of a 10 like normal, they're going to get a 5, right, for perfusion. So what happens is you end up with this V, ventilation to perfusion mismatch, and in this case it's increased because 10 over 5 is 2 instead of 10 over 10, which is 1, right? So I'll do it up here. Normally we might be 10 over 10 and that equals 1, but now 10 over 5, that's 2. So you end up with an increased VQ mismatch. And so this is occasionally tested. I think it's a little advanced, but it is tested. So that is this whole VQ mismatch that students get lost in the sauce on. So let me recapitulate this, right? What is a pulmonary embolism? It is someone who is sedentary, international flight, recovering from a surgery, has a leg immobilized in a cast, right? Someone on oral contraceptives, a smoker, something to that effect, okay? And they end up with a blood clot below their knee, or right in their knee cavity, in their vein, right? And that's called a deep vein thrombosis. And eventually that'll launch off. And what's the sign of a deep vein thrombosis? A warm, hot, swollen, painful leg below from the knee down. And so that'll launch off and it'll travel up to their pulmonic artery and it'll block off the blood highway to that section of the lung. And that is a pulmonic or pulmonary embolism. And so how does and so this it may also occur as a result of damage to the lining of vessels or hypercoagulability, right? So if our blood likes to clot really easily, then that's how this can happen. And slow blood flow in a lower extremity. Again, if someone's laying flat in a hospital bed for a long period of time, this can happen, and it happens often. And so risk factors, I'm going to read these to you because it's important. Immobilized legs, recent surgery, pregnancy, previous pulmonary embolisms, relative with a pulmonary embolism, obesity, oral contraceptives, I'll come back to that, smoking, infection, cancer, sickle cell anemia, that's complicated, but prolonged inactivity or being bedridden. So you'd think yourself, like, what? Why oral contraceptives for the ladies in the room? It's because estrogen increases coagulability, and so does progesterone. And so basically, when you start taking oral contraceptives, they increase the clotting factors in your blood. So I'll go a step further. A woman over 35 who has a smoking history cannot take oral contraceptives for that reason. The risk of DVT becomes so high. This actually happens. I have a very good friend that got a DVT. She was 29 years old, taking birth control, got a massive PE. She didn't die, but from being on oral contraceptives, didn't smoke either. So just know this does happen. These are common. So how does this present? Okay, shortness of breath, tachycardia and tachypnea, so fast heart, fast breathing, varying degrees of hypoxia, cyanosis, acute chest pain. They can have like sharp chest pain, hemoptysis. What is hemoptysis? Right, good question. This is coughing. Whoops. This is coughing up blood. Okay, so if they tell you patient's coughing up blood, you need to be thinking probably tuberculosis, which is a bacterial infection that doesn't really happen in the United States very often. But if it does happen, it's almost always an immigrant or homeless person. Or coughing up blood, you need to be thinking, oh, this might be cancer or PE, pulmonary embolism. Now, something I tell my students to look for, and you'll see this clinically, is the patient that's telling you, I can't breathe with perfectly clear lung sounds, you need to think that is a PE until proven otherwise. I'll say that again. If you have a patient who tells you, I cannot breathe, I am short of breath, and you listen to their lung sounds and they're clear, you need to think this is a pulmonary embolism until you can definitively prove otherwise, which you cannot in the pre-hospital environment. That needs to be done in the hospital through blood work and a CT. So realize this happens. I'll tell you an embarrassing story. When I was in paramedic school, I remember this call. We ran this lady. She was screaming, literally yelling at me. I can't breathe. I can't breathe. I can't breathe. She had just gotten out of the hospital for ankle repair. Right? She had like an ankle fracture. It was there for like a week. She had been home for 2 days in bed. And so what happened was I, thinking I'm some big bad paramedic student, wrote it off. We just took her to the hospital, put it on her breather. I'm telling her, you need to calm down. You need to calm down. I wasn't being a good paramedic. And sure enough, I told my mom, who's a nurse and a paramedic, and she's like, "Oh, Hunter, that's a PE." And in hindsight, yes, it was definitely a PE. Like she had all the symptoms. Because I was like, "No, you're not short of breath, ma'am. Your lungs are perfectly clear, right?" So I'll say that again. Someone who has clear lung sounds, who's telling you, "I cannot breathe," you need to think this is a PE until proven otherwise. Did you notice anywhere on this list they said anything about lung sounds being altered? They're not. Lung sounds are typically clear in PE, okay, at least at the beginning phases of this. So be careful and watch for that. You will see that clinically and on exams. Now, obstruction of the airway. So basically, this can happen for a variety of reasons. The most common airway obstruction is the tongue. I'll say that again, test question. The most common airway obstruction is the tongue. But, and you see this right here, right? So when we sleep, your muscles can become so relaxed in your airway, especially if you sleep on your back, your tongue will fall and lay back on your oral pharynx and will cause obstruction. So when we breathe in, that causes snoring. And so sometimes this will create a pathology known as OSA, obstructive sleep apnea. So how do you fix this? There's a lot like dental appliances or CPAP, right? A CPAP machine, like a face mask, you've probably seen those. Now, another common airway obstruction would be food, right? Or batteries, or toys, or coins, or whatever. Kids stick all sorts of weird stuff in their mouth. So for kids, it's usually like a foreign body. For adults, it's usually food. I almost died once on a mozzarella stick. I'm not kidding. Like my dad actually did the Heimlich on me. So food is a common airway obstruction, and this creates a real problem for us as EMS or as EMTs because you can't ventilate someone with a BVM if there's a deviled egg. Or I just ran one a couple years ago when I was back on the truck. A lady, it was grapes. It was a grape was stuck in her trachea, could not get past it. So we ended up intubating her, which we shoved a tube down her throat, and I just shoved the grape all the way down into her lung because she was dead. She was in cardiac arrest. So just know that, like, yeah, food is a common airway obstruction, but what's the most common airway obstruction? It's the tongue. It's the tongue. And if you think of what an OPA is, right, an oral pharyngeal airway, like that's to lift out and displace the tongue. Okay. So an unresponsive patient, this may result in vomitus, right? That's the medical word for vomit, foreign body, or the tongue blocking the airway. Those are all common airway obstructions, okay? So environmental industrial exposure. So just be aware that pesticides, cleaning solutions, chemicals, chlorine, carbon monoxide. Remember, carbon monoxide is the byproduct of incomplete combustion of organic material, right? Or really any material. And so that burns. And so it's carbon monoxide, CO, okay? Remember, CO2 is different. That's the byproduct of cellular respiration. Other gases, right? These can all cause airway issues for us, respiratory issues. So some chemicals can combine to create this hazardous gas or hazardous byproduct, right? So the type of damage it'll depend on several factors. The first one is the water solubility or the ability of it to be absorbed into your body. Chlorine, it would be quickly absorbed and very caustic. Carbon monoxide is extreme. It has an extreme affinity to bind into your blood cells. It binds around 260 times easier to your hemoglobin than oxygen does. And uh, and so what I'm saying is, what they're saying here is highly water soluble gases cause swelling and irritation, but the less water soluble gases can cause pulmonary edema up to 24 hours later. So what does that mean, right? So that means someone could be exposed to a poisonous gas today, and we check them out, and they might be coughing, a little irritated, but they're okay. But that doesn't mean they don't need to go to the hospital, because hours from now, or even a day or two from now, they could end up with flash pulmonary edema or some type of pulmonary irritation or pulmonary emergency. So just realize that sometimes it is a little bit delayed, okay? And that could show up on an exam. But just because it wasn't instant doesn't mean that it didn't have, just because they don't instantly have irritation or problems doesn't mean that they won't, okay? We can't write that off. Now, cystic fibrosis, sometimes you'll hear this called CF. Cystic fibrosis, it's a genetic disease, okay? And so basically what happens is we have salt and chloride channels, and what happens, the most common way this happens, there's about 100, and I'm not kidding, hundreds of different ways this can happen genetically, is the most common way this happens is you have a switch of the salt and chloride channels within the body, okay? So how this happens is, instead of having fluid into the lumen of the bronchioles, it ends up drying up because the salt and chloride channels have been reversed, or they're not working properly. So you'll end up with something called dissipation. And so what happens is the mucus becomes very thick. because there's not a lot of water in the lumen of the airways. And so it becomes really, really, really thick mucus. So this creates an obstructive type pathology, and of course it creates bronchiectasis and it creates infection. And so how this will present is a patient with frequent lung infections and coughing up mucus. I mean, they know they have cystic fibrosis, but it'll cause death. This is fatal. Like most CF patients don't live past 30 or 40, even today with modern treatment. And so it's a very bad disease. And I'll have you know, this is almost always in Caucasians. It's almost always in white people. So it can create asthma-like complaints. That you just treat them with supportively. Now, I will say you can see this occasionally, and this is probably a little advanced, but it's worth knowing. You could do something called chest percussion therapy, CPT. So you can cup your hand like this and try to, like, if you have like someone in severe cystic fibrosis, you can try to like percuss their chest to try to break up that mucus. That's a last ditch effort. We really don't want to get there, but you'll see that. And one thing I'll say about chronic diseases like this, especially chronic diseases of childhood, like cystic fibrosis, the parents and the caregivers are the experts, not you, okay? You're literally getting one slide in EMT school about cystic fibrosis, but they've been living with this for years. So they're going to know a lot about the disorder and how to treat it and troubleshoot it. So do lean in heavily on the family when you encounter these types of fairly rare chronic childhood disorders or chronic disorders that are fairly rare, okay? Now, age-related conditions. Oh my God, I'm seeing this all the time. So it's the day after Thanksgiving that I'm recording this, and I'm doing my pediatric hospitalist rotations right now. And so basically, if we have 70 patients admitted, 50 of them have RSV. I'm not making that number up. And so what happens is RSV is a virus, okay, and it affects the really young and the really old, but especially the really young. And so this is why you don't kiss people's babies, okay? Because it's very, very, very virulent. It's very contagious, okay? And for adults, I probably have RSV right now because my nose is a little congested and stuff like that. And I'm seeing like 50 RSV patients a day. But yes, I'm wearing a mask though. But anyways, what happens is for me as an adult, I'm okay. I don't feel great. I'm a little nasally. I'll be okay. But for a kid who can't raise their hand and be like, hey, buddy, my nose is stopped up. I can't breathe. They end up with a pretty severe infection and they end up with something called bronchiolitis. So the bronchioles will become inflamed, and what happens is so RSV stands for respiratory syncytial virus. So the syncytium of the respiratory system, or really any cell, is kind of like the webbing in between cells. And so the syncytium becomes inflamed. And so through the inflammatory response, the bronchioles will slough, right? So it ends up sloughing off its cells into the bronchioles. Well, that creates this inflammatory response and this huge mucus production. So this is characterized by sloughing of the bronchioles eventually and massive massive mucus production. And so the baby will be very congested. They will have a hard time feeding and latching onto a nipple or a bottle because remember, babies are obligatory nose breathers. But if their nose is stopped up, they can't breathe. So they certainly aren't going to latch onto a nipple. So they end up with dehydration and failure to thrive, and they're not eating very well. And so like all these poor nutrition, congestion, coughing, fever, okay? So it's highly contagious. I can't stress how contagious this is. So don't touch people's freaking kids in winter. It's awful to do that. And so the hallmark of this treatment is frequent suctioning. I have one over there, but bulb suctioning. A lot of times you have to suction these kids' nose out, and then also hydration, right? So you want to encourage hydration. But these kids get hospitalized, and this can be fatal. I mean, it isn't typically fatal, but they certainly get hospitalized for sometimes 3, 4, 5 days at a time. And that's obviously very expensive and not healthy for the parent or the child, or ideal. So yeah, RSV, it causes bronchiolitis, okay? You see this in newborns. I say newborns typically 2 years or less, but you do see this in the first year of life a lot. Whoops. Croup, I talked about this. It's caused by the paramyxovirus, so it's a virus. And so remember when I drew the trachea, it normally looks like this, but in croup, the trachea will become inflamed, so it looks like this, okay? And we call this steeple sign. And so basically it's swelling of the pharynx, larynx, and trachea. It's often due to a viral infection, and it's the upper respiratory tract, but it's not necessarily the upper airways, but it is the upper respiratory tract. Remember, the upper airway is the larynx and up. So basically, the hallmark sign is stridor, okay? And they'll have a seal-bark cough. I'm not going to replicate that again, but a stridor. So stridor sounds like this. right? It's inspiratory, high pitched upper airway sound. So, like, you could literally take a stethoscope. You wouldn't need to because you can hear stridor without a stethoscope, and like listen to my trachea, and you'll hear this high pitched inspiratory sound, and that's stridor. And so it presents with a Silbart cough. And so when they cough, it has this very distinct sound that sounds like a seal. Okay. So this is croup. It's a viral infection. Again, it's contagious. This typically happens in children less than 10 years of age. Now, epiglottitis, again, bacterial infection, very can be very fatal. There is a vaccine for this, so you don't see this a lot, but it's a true life-threatening medical emergency when this happens. Man, I think I saw this once working at Cook Children's, but this is rare because there's a vaccine for it. It's bacterial. So what happens is the epiglottis is that little flap that sits over our larynx. So when we swallow, it covers up the hole that our vocal cords and our windpipe. So it'll get swollen and infected from this bacteria, Haemophilus influenza type B. And so it covers it up. And so basically it becomes so inflamed. So the hallmark of this, sore throat, high fever, stridor, right? Upper airway, stridor. Tripod positioning, we know what that looks like. A lot of times they'll even be in the sniffing position, and drooling. They don't. It hurts so bad to swallow, to move that epiglottis when we swallow. They won't swallow their spit or their saliva, so they'll just drool. Very characteristic of this disorder. This is a true medical emergency. Why do I keep saying that? Because if the epiglottis becomes so swollen that it pushes down on the windpipe or the larynx, the vocal cords, that you can't get air in, what's your option as an EMT? You don't have one. As a paramedic or physician, the option is to cut their throat and do a surgical airway. You don't want to go there, right? This is a true medical emergency. So be very careful with these patients. The treatment is supportive care as an EMT, and to not irritate the child. Because if you irritate them, they start crying, you can make the inflammation worse. Pneumonia. So this is infection of the lung parenchyma. So this happens. I mean, usually it's almost always it's going to be a bacterial infection, but young children and older adults are at the greatest risk. Okay, so it's typically localized infection of the lung. It can be bilateral, right? That typically happens in people my age, like mycoplasma pneumoniae, but it can happen on both sides of the lungs. Let me say that. But it typically, prototypically, what you'll get on exam is they'll isolate it, typically in the bases. So they'll say the patient has right lower lobe bronchi, right, in rails. Okay. And so remember, bronchi sounds like mucus in the lungs. It sounds like you're breathing through snot because you are. And so you end up with this like purulent, which is like pus, sputum, pleuritic chest pain. So it'll hurt where that area is inflamed and where the infection is. You can get a pleural effusion. What's a pleural effusion? That's when fluid builds up in that cavity. And you'll get definitely excess mucus. So they'll be coughing up pus and mucus and stuff like that. So a good question is, what color is your mucus, right? If they're like, oh, it's like a whitish greenish color, yeah, it might be pneumonia. But you'll hear this with the stethoscope. It's very hallmark, right? You'll listen to the lower bases and you'll hear like, oh, it sounds like they're breathing through a hot fudge shake on the right side. And you listen to the left and it's clear, or it's mostly clear. It's pneumonia. So pneumonia is almost always a bacterial infection. So just knowing it's probably pretty much a bacterial infection, okay? Now, pertussis is known as the whooping cough, okay? Now, this happens in young people almost exclusively. There is a vaccine for this. So again, if a child's vaccinated, you probably won't see this, but I have seen this clinically twice. And so basically, I've seen it more than that probably. What happens with whooping cough, like I said, there's a vaccine. It's a bacterial infection. And so it's typically children less than 6 years of age, but basically they'll have like cold flu-like symptoms, but they'll be coughing so much, like when they're coughing so hard by this toxin that's produced from the bacteria, that when they finally get a chance to breathe in, it has this like whooping sound, right? And so it's called the whooping cough. And so it's characteristic sound, and it really does sound like that. Now, a few things you need to know about this, which is probably a little extra, but I want you to know, is this can produce, which is weird, it can present with hypoglycemia, which means low blood sugar, normal blood sugar range between 70 and 120. And more than important, it'll present, you'll see this a lot, something called post-tussive emesis. So they cough so much they end up vomiting. So they'll just like cough, 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 and then just vomit because they're that like they're gagging, right? Like they're coughing that hard. And so the cough typically isn't very productive either. What's causing this cough is the bacteria produces a toxin. And this is like part of the Tdap vaccine, right? Tetanus, diphtheria, pertussis. And so basically what happens is they produces a toxin that stimulates through, I'm not going to talk about how this happens, but it stimulates the body to cough. Okay. This is a young person disease, 6 years or younger. Shouldn't happen to people like you and I. And plus, we're vaccinated, so really shouldn't happen, but it does. Now, airway obstruction. So always consider the possibility of foreign body with a young child who becomes short of breath. You do see this. What sound will you hear with a foreign body airway obstruction? Typically stridor. Okay, so it'll present with stridor, and so you can also have. So that's what's called a foreign body airway obstruction. Okay, FBAO, right? Foreign body airway obstruction, and so it's a foreign body. It could be a battery or a toy car or a coin or a you know food or a rock or a peanut, who knows? Okay, and it can get stuck anywhere, and it can even make its way down into the lungs, right? So if it goes down into the lungs, I want you to know it's almost always the right lung that it'll go into. Okay, let me draw this for you. Excuse me. If this is the trachea and this is the carina, and this is the patient's right side, it's a lot easier to go there because the left lung kind of goes like, or the left bronchus kind of juts off like this. So if you think about it, it's easier for the peanut to roll down and go this way. It's pretty difficult, unless they're laying on their left side, for it to go that way. Just fun fact for you. Okay. So typically we see foreign body airway obstructions. If they make their way down into the lung, it's going to be in the right lung. Okay. Now, the tonsils can become inflamed and partially occlude the airway. Now, you can see this in strep pharyngitis, which is a bacterial infection, but more commonly where I've seen like the tonsils be so bad is in Epstein-Barr virus, monovirus. So that's the kissing disease you've probably heard of. It can become very inflamed in mono. Very, very inflamed. That's a viral infection. Typically, this can happen in adolescence, right? It's the kissing disease. And so you'll end up with massive tonsils that are inflamed. Again, you can see this in the bacterial infection of strep pharyngitis, right? Group A strep. But just know that happens, okay? So dysfunction of a tracheostomy may create an upper airway obstruction. So a tracheostomy is where they'll put a little hole in the trachea and put a tube down through here. You typically see this in chronically ill children or adults, right, that have some type of something isn't causing them to not breathe properly where they've had to do that. Okay, could be cancer, could be cystic fibrosis, neurogenic disorders, retardation, something like that. Something has happened. Brain injury, insults, cerebral palsy, something like that. Now, obstructed maybe in the lower airways. So if we could have tracheal trauma, right? So from a hanging or from choking or something like that. Obstructive lung disease. What are obstructive lung diseases? Asthma, COPD, emphysema, bronchitis, bronchiectasis. Those are the more common ones. Remember, on an exam, if you have to pick one, it's probably going to be obstructive rather than restrictive. Mucus accumulation, we've talked about this, or smooth muscle spasm. Both mucus accumulation and smooth muscle spasm will result in obstructive pathology. Now, lastly, maybe it is lastly. We're getting close, okay? I think there's like 2 more slides. Heart failure is heart muscle. So remember, the heart is a muscle and it doesn't regenerate, okay? So when it becomes injured from a heart attack or some type of issue, it's almost always a heart attack, right? So it doesn't regen. So when this muscle dies, it doesn't regenerate. So it just stays dead. And so imagine like a pump and you just take out like a chunk of the pump. The pump's not going to become very efficient. So, or you could do the same thing with my bicep, right? You take like a quarter of my bicep out, I'm not going to be able to lift as much weight. So the same thing happens to the heart. And so this will result, and we talked about how this happened earlier, in pulmonary edema. What's the sound that pulmonary edema makes? It's crackles, formerly known as rails. And so the risk factor for heart failure is hypertension, which is high blood pressure, and that'll typically cause the left side of the heart to fail, which will then back fluid up into the lungs. We end up with pulmonary edema, then the right side of the heart fails. Okay, so that's the typical progression. More than 70% of the time, that's how it happens. I'm making that number up, but the majority of the time, that's how it will happen. It's because of hypertension or from past coronary artery disease. So again, if I have a coronary artery that supplies the muscle of my heart, if it's blocked off, so that chunk of my heart dies from a heart attack, then it doesn't regenerate. It just scars over and it makes your pump not very efficient. Now, signs and symptoms of heart failure will be shortness of breath, Sudden attack of respiratory distress, so sudden dyspnea. They're going to feel suffocated. They might have the cold sweats, which I hate they use that word. The medical word for this is diaphoresis. You'll see that on exams. Diaphoresis. It's the medical word for sweating. And tachycardia. But there's another word we use for pulmonary edema. When you can't lay flat, the patient will prefer to sit up or sleep in a recliner or use a lot of pillows, right? That word is called orthopnea. Remember that word, it's very important. Orthopnea. So here's what I've told my students in the past, and it tends to work. As a generality, if you hear the word orthopnea, or I'm sorry, if you hear the word crackles or rails, you should first think, is this heart failure? And then work your way out of convincing yourself it's not heart failure. And how do we get heart failure? From heart attacks or from long-standing hypertension. And why am I telling you that? Because in the cardiac chapter, the next chapter, what happens is they'll be like, the patient has chest pain and they have rails, what, blah, 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 blah. What's the cause of this? And patients and students will choose COPD or asthma or something, and it's wrong. The answer is acute coronary syndrome, right? Heart attack, right? From their heart attack is causing their heart to fail, which is causing fluid to back up into their lungs, which is presenting the sound of rails or crackles, okay? So that's an important thing that I want you to know, that for the majority of times when you hear the word crackles or rails, I want you to be thinking, this is probably heart failure from a heart attack or long-standing hypertension, and I need to convince myself it's not. Okay. Now, if they tell you, oh, the patient's a 28-year-old male with, rhonchi in the right lower lobe and he has crackles, right? It's not heart failure, right? It's pneumonia, right? Rhonchi equals pneumonia, usually. So just you have to be a clinician. You have to use your thinking cap on that one. But just as a general rule, I found that helped a lot of students last semester. Whoops, wrong way. Now, wet lungs are associated with pulmonary edema. Dry lungs are associated with COPD. So again, pulmonary edema is almost always from long-standing hypertension or from acute coronary syndrome, right? Heart attacks. Breath sounds are helpful, but they can also be confusing, right? Treat the patient, not the breath sounds, okay? And we're going to jump into this in the next one. Let's take a quick break, and then we'll jump into part 3. This is going to, the last part will cover, like, patient assessment and treatments for each of these. So what's cool is we're going to jump into, like, we're going to kind of recapitulate, oh, I told you about pertussis, or I told you about croup, and here's the treatments, and blah, 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 blah. So with that, let's take a quick break, and then we'll finish up this series.